Hello, and welcome to the ISTH World Thrombosis Day Ask the Expert series. Today we will be discussing thrombophilia testing, specifically MTHFR polymorphisms and why they are not helpful in inherited thrombophilia testing. I'm Jean Connors, your host today. I'm from the Dana-Farber Cancer Institute, Brigham and Women's Hospital, and Harvard Medical School in Boston. I'm a member of the World Thrombosis Day Steering Committee, and I'm pleased to be joined today by Steering Committee Chair Professor Beverley Hunt. She's Professor of Thrombosis and Hemostasis at King's College London and a consultant at Guy's and St. Thomas's Hospitals. Professor Hunt, Beverley, welcome, and it's great to have you with us today.
It's lovely to be here, June, especially with you.
Well, thanks, and back at you, Beverley. So Beverley and I co-authored a position paper along with other members of the World Thrombosis Steering Day Committee on methylene tetrahydrofolate reductase, commonly known as MTHFR, gene polymorphisms. We look forward to discussing our findings and recommendations in today's video. So now I'm going to get started with Quiz the Expert. Beverley, let's begin with the basics. MTHFR is not an acronym that many people outside the medical field have heard of. Can you please briefly explain what the MTHFR gene is and how it is used in thrombophilia testing?
MTHFR is short for methylene tetrahydrofolate reductase, which is an enzyme that's involved in the breakdown of a substance called homocysteine, and too much homocysteine is not a good thing. It's a bit of a toxin in the body. So it's important that it works well. And one of the issues with it is that it can have polymorphisms in it. And some of the polymorphisms can mean that MTHFR doesn't work so well.
So why would someone send this test?
Well, Jean, as we have discussed and we're going to discuss today, we're going to prove that MTHFR shouldn't really be part of a thrombophilia screen, but it is a test that one would do if someone had very, very high homocysteine levels and you thought that they had an inherited problem with homocysteine metabolism. And there are a group of patients who are very rare who might have a problem there. So it's worth doing in metabolic analysis for a rare group of patients, but it shouldn't be used in thrombophilia testing. And by thrombophilia testing, I mean that we are testing for predisposing factors towards thrombosis. And those predisposing factors mainly cause venous thromboembolism, not arterial. So they don't tend to cause heart attacks or strokes. They tend to cause deep vein thrombosis and pulmonary embolism.
So in other words, you're suggesting when you discuss metabolic testing that people might send the homocysteine level first, and only if it's significantly elevated do MTHFR testing, but maybe not for thrombosis risk. Can you elaborate a bit more on that?
So it's a funny test because it was discovered that about 15 years ago that there was a polymorphism. So there was a mutation within the gene that meant if you had low levels of folic acid, which is a vitamin, it wouldn't work. MTHFR wouldn't work so well, and that meant that you would accumulate homocysteine a little bit, so your levels would tend to be a little bit higher than normal. And people got terribly excited about this because they thought that homocysteine was a risk factor for having venous thromboembolism. So everybody started measuring it. There were numerous papers where they looked at tiny groups of patients and they'd say, oh, there's a problem with MTHFR in this group of patients. And they attributed the problems in the patients to this polymorphism. And what's happened is that MTHFR testing got incorporated into thrombophilia testing without it properly being evaluated. And in the last 5 years, we've had a lot of beautiful randomized controlled trials looking at the role of homocysteine and MTHFR in the causation of venous thromboembolism. And essentially, they have shown there is no real relationship between what MTHFR polymorphisms you have and your risk of thrombosis. And the real problem with MTHFR is that there's one particular polymorphism that's occurring where about 46% of the population are heterozygous and 12% are homozygous. And everybody looks for this. And those who don't seem to know that much about thrombosis have been saying, you're heterozygous for MTHFR polymorphism, therefore you've got increased risk of thrombosis. And that just isn't true. So, Jean, we have been working together to try to get laboratories to remove MTHFR testing from their thrombophilia testing. And many labs have, but we have been left with a minority of labs that keep measuring this particular polymorphism. It's expensive. And when patients are told, oh, you're heterozygous or homozygous for this particular polymorphism, it's causing worry in them, whereas we know that it's just normal to have this heterozygous or homozygous state. So we want people to persuade their laboratories to remove this from thrombophilia testing.
So, Beverley, it sounds like there may have been a lot of hype and potentially hope about the usefulness of MTHFR testing, but the data that we now have clearly show that it really hasn't panned out. It sounds like there is a gap in understanding from both laboratories and perhaps clinicians who continue to order this test despite the data that show that it is not as useful as we first hoped. Can you elaborate more on how we might get that message out? Do you think the position paper and the call to action manuscript that we wrote for RPTH is important? And what do you think about moving this forward?
So we've got to take the message out there, and so it's very useful to have short videos like this so that we can explain the problem to thrombosis professionals and those who run the laboratories so that they can remove this unnecessary test from thrombophilia testing.
And it sounds like, Beverley, that you've already touched on key reasons for the benefits of removing this testing from standard practice. Not only the cost savings, where you just recently discussed that it's costly test, but also the anxiety that occurs in patients. And could you perhaps give us some examples of the person that is told they are heterozygous for MTHFR, and how might that negatively impact their health?
So I see a number of patients in clinic who are referred up who have got abnormalities on their thrombophilia testing. They might be done in another lab and they might be heterozygous for MTHFR. And they've been told that that is a risk factor for them having thrombosis in the future. So it induces worry in the patient, and quite often they've come from a private laboratory, so they've had to pay for it. If they've come from a state laboratory in the UK, as you know, we have free healthcare, that laboratory has spent the nation's money unnecessarily. So there are many reasons for it to be removed. It's just unnecessary.
So in contrast, here in the United States, I think commercial insurance will likely pay for this test, but the anxiety that I see in patients that you've experienced with your patients is definitely true. I've seen patients overtreated And even some women with pregnancy and perhaps pregnancy loss is attributed to the MTHFR, and then they're treated with enoxaparin or other low molecular weight heparins throughout pregnancy. When I see them after the fact, I am sometimes significantly or brutally honest that they probably didn't need the enoxaparin during pregnancy. And so I think that we can summarize everything that you've said by saying perhaps MTHFR testing does more harm than it does good. How about patients, though, that need inherited thrombophilia testing? Do you think those patients are out there? And if yes, how would you work somebody up for an inherited thrombophilia?
So we have a set repertoire of tests that we would do, and we have got high-risk thrombophilias, and those are looking at the levels of the physiological anticoagulants. We know that if you're deficient in protein antithrombin or protein C or protein S, you have increased risk of thrombosis. The risk often depends on your mutation, and these days we usually, once we found the low level, go on and look at the gene. And then we have the low risk thrombophilias, and they include the quite famous now factor V Leiden. Factor V Leiden is present in about 5 to 10% of Caucasians, depending on where you live in the world. By Caucasian, I mean a white person. We never see it in Black populations, occasionally in Asian populations, and it increases your risk of thrombosis if you're heterozygous by about 8-fold. If you're homozygous, and that's probably about 1 in 1,600 in the white population, that greatly increases your risk, probably to 80-fold compared with the background risk. And lastly, we have prothrombin 2210. That's a polymorphism in the prothrombin gene, and the patients that have higher levels of prothrombin, and they have double the risk of thrombosis. Quite often it's combined with another, and it seems to predispose more to cerebral venous sinus thrombosis and abdominal thrombosis. And then that's really it for the stark inherited thrombophilias. Would you test for any more, Jean?
No, actually, I agree completely with the basically the 5 tests that you've mentioned: protein C and protein S levels, antithrombin levels, and the factor V Leiden mutation and the prothrombin gene mutation or polymorphism. People have been looking for other tests such as factor VIII levels or similar other inherited risks, but none have really panned out and none have been validated to be truly associated with risk of VTE. And so, it's interesting because there's a bit of controversy about who should be tested or whom should be tested for inherited thrombophilia testing. And we note in our manuscript that many medical guidelines and societies give recommendations about testing, yet again, these tests show up in panels. They include MTHFR. So why do you think it is that these tests are still sort of at least in the United States, where cost may not be the barrier that it is in the UK, they are really sometimes inappropriately and indiscriminately sent on patients?
Well, we're very much governed by the National Institute of Clinical Excellence, and they have said to us, and we have to follow their guidance, not to use inherited thrombophilia testing unless it's going to change the management of the patient. And where we're advised to use it is in patients who've had a venous thromboembolism that's unprovoked, and we're not sure whether or not that we need to continue anticoagulation, and they've got a family history of venous thromboembolism. So that is really the very small area you would argue that one should test. Of course, others would use the testing in all unprovoked patients. And actually, we've recently done a survey, an international survey of about 130 consultants in thrombosis and hemostasis, and there is quite a lot of variability in the experts and what the experts do, and many would do inherited thrombophilia after an unprovoked clot. But I think, thankfully, most of us agree if you've got a provoked clot, clear provoking factor, you have removed the provoking factor, you do not need to do thrombophilia testing.
Yes, well, I agree with that statement completely. I tend to be one who does not do a lot of thrombophilia testing, but as you alluded to, the experts still have some controversy. Here in the United States, we find, because we don't have the nice guidelines and are regulated to some degree by what the guidelines say, we find patients admitted to the emergency department, not even admitted to hospital, getting these tests. We find patients having arterial events, having these tests, which primarily predict venous thrombosis and increase the risk for venous thrombosis. So perhaps the United States should adopt an agency like NICE, but that's for another discussion. So, we've talked now about this testing and the controversy. Do you think there is room for change in the healthcare profession? Do you think that we can actually implement changes to sort of decrease inappropriate testing, or certainly for MTHFR, eliminate it completely?
So I think that healthcare has got incredibly complex, and if you're a physician and you only occasionally see a patient with a deep vein thrombosis or pulmonary embolism, you can't remember how to deliver your care. And in that setting, I think that the laboratories should provide some guidance. And so when we use our healthcare electronic system, it says when you request inherited thrombophilia testing, we only would allow you to do this in these certain settings. And so it's quite educational if you do it in that way and you say, no, we don't allow it for this situation because it's of no benefit. So I think it's up to the thrombosis community to help physicians who only do thrombosis now and again. And of course, there's so much thrombosis around, there aren't enough thrombosis experts. So patients have to be seen by people who do other things as well, that we help them use the tests that are available safely and effectively.
That's an excellent strategy. I know of some in the United States who've implemented a strategy in their institution, but we do not have the national level pull that you have in the UK. And I think that that's excellent because, to your point, thrombosis affects almost every discipline, both medical and surgical disciplines, and it goes across all different disease and organ specialties. And so you're right, many people are trying to manage, or many clinicians are trying to manage VTE, but don't consider it their area of expertise. And so providing that guidance, I think, is an excellent strategy to try to help it decrease cost and decrease unnecessary testing, and most importantly, decreasing the anxiety we see in our patients when some inappropriate tests, such as MTHFR, are done. So I'd like to thank you, Professor Hunt, for your expertise and guidance today. For the audience, we want to thank you for joining us. If you'd like to read a copy of our manuscript, the call to action paper on MTHFR testing and why it should not be performed, please look for it in Research and Practice in Thrombosis and Hemostasis. I'd like to direct everybody to the World Thrombosis Day website, where you can find more information on blood clots, including the resources I just discussed and our MTHFR position paper at www.worldthrombosis.day, all one string, www.worldthrombosis.day.org. I'd like to thank everyone for joining us, and most importantly, thank you, Beverley.